and welcome to Askimo TV. We're talking today to Dr. Heather Currie. Dr. Currie is a gynecologist from Scotland, specializing in menopause. She's the founder and MD of Menopause Matters Limited, the Honorary Secretary of the British Menopause Society, and co-editor of Menopause International, the Journey of the British Menopause Society. Hi, Dr. Currie, how are you?
I'm very well, thank you.
Wonderful. Dr. Currie, we're going to be having a discussion today about menopause and some various questions that women may be asking themselves. So let's begin with, does every woman suffer severe menopause symptoms?
Not everyone, but most people. It's estimated that around 85% of women notice some symptoms due to the menopause, i.e. due to the lack of estrogen, which is what really this is all about. It varies in severity and it varies in duration. So some women may have some mild symptoms that only last for a short while, and there are a few that don't seem to notice any at all, other than obviously the obvious absence of their periods. But there are some women who have severe symptoms. So there's a great variation in the severity. There's also a huge variation in duration in that, as I've said, some women only last a short while, others it can go on for many years, in fact, occasionally forever. So when we're looking at thinking about treatment options, it's very difficult to predict how long treatments will be needed for, because some women vary hugely, and some women will only need treatment for a short while, others may need it lifelong. So which is why we're managing the menopause or advising on the menopause. We have to individualise. There isn't a blanket approach, and we have to try and help women work out what's best for them. It is baffling to me that actually there's a lot about the menopausal symptoms that we know very little. We've known about these symptoms, particularly flushes and sweats, for many, many years, and yet we still don't know why there is such variation in the onset of the symptoms and the impact that they have on women.
What is hormone therapy?
Hormone therapy is really replacing the hormones that we've stopped producing. So the whole thing about menopause, the consequences of it, the early symptoms, the later health problems, is related to our ovaries running out of egg cells and not being able to produce the important hormones estrogen and progesterone. So estrogen is a key hormone. It's important for many, many systems in our body, and the whole point of the consequences are due to estrogen deficiency. So hormone therapy aims to give back the estrogen, and it does in as natural a way as possible. There's been lots and lots of research about hormone therapy, and we're pretty much at the stage where we are able to give back estrogen in a very natural form. Estrogen can have a huge effect on reducing menopausal symptoms and can have effect on bone health and heart health. If we just give estrogen on its own, it can stimulate the lining of the womb. So unless a woman has had a hysterectomy, had her womb removed, she also needs to take an additional hormone, progesterone. So this is mimicking the progesterone that we produce normally in the second half of the cycle, which regulates the lining of the womb. So the progesterone is purely given to look after the lining of the womb, and there's different ways of giving that. So in the majority of women who still have the womb, HRT or hormone therapy, in fact, has two hormones, it's estrogen and progesterone. If a woman has had a hysterectomy, had a womb removed, then all she needs to take for hormone therapy is estrogen.
Does hormone replacement therapy prevent osteoporosis?
Hormone replacement therapy is very good for the bones. So we know that estrogen has a big effect on the bone, on the effect of in the bone itself. There are two types of cells. There are osteoblasts and osteoclasts. Osteoblasts are the bone builders, so they're constantly building new bone. Osteoclasts are eating up bone and mopping up and reducing the bone density. There's a fine balance goes on between the two, and estrogen is really important for maintaining that balance. So with the lack of estrogen, we have more effect of the bone munchers, the osteoclasts, and less effect of the bone builders. So with the lack of estrogen, we know that there's a significant drop in our bone density following the menopause if we don't take replacement therapy. And if we think about women who go into menopause at a younger age than normal, the more years we expect to be without estrogen, the bigger there can be effect on the bones. Estrogen also has effect on calcium absorption from the bowel, and so with less estrogen, there's less calcium absorbed, which again is detrimental for bones. So in fact, to summarise that, when we take estrogen or hormone replacement therapy, that has a very good effect on maintaining the thickness, the strength of the bones, and reducing the risk of osteoporotic fracture. So it is in fact very good for the bones. And the people in whom that's particularly important are the women who suffer from an early or premature menopause. And in fact, recent research that was published last year showed that even having menopause just under the age of 47 can significantly increase the risk of having an osteoporotic fracture. And so women who have menopause even just in the early 40s should be considering the use of hormone therapy and should be thinking about taking it at least until the average age of the menopause to look after the bones.
Is there a link between breast cancer and hormone replacement therapy?
That's a really good question, and is the issue that most concerns women who have been taking hormone replacement therapy or who are considering taking it. The current understanding is that we do not believe that hormone replacement therapy causes cells in the breast to turn into cancer. What we believe is that in some women, if certain types of HRT are taken long enough, there may be an increase in the growth of cancer cells which are already there. Because what we often don't realise is that for cells in the breast to turn into cancer, it takes many years before they actually become evident, either as a lump or picked up on screening. So the belief is that in some women, there may be an increase in the growth of cells that's already there with the long-term use of HRT. So if we think about young women, first of all, we actually don't start counting until the early 50s because those who are taking hormone replacement therapy are replacing the hormones that normally would be produced anyway. So just replacing that, and their breast cancer doesn't increase in risk unless they take it beyond the average age of the menopause. And the current thinking is that you have to probably take it at least 5 years beyond the age of 50 before there's any small increased risk of the diagnosis of breast cancer. It is very much affected by different types of HRT. So the women that I referred to earlier that have had a hysterectomy who take estrogen only, they probably don't have any increased risk until they take it for many, many more years. The women who are using estrogen and progesterone may have a small increased risk taken for more than 5 years after the age of 50, but it also depends on the route of estrogen and the type of progesterone. And there are some types of progesterone that we're beginning to get information about as being less breast risk than others. It is difficult to quantify risk, and a really important thing to bear in mind that, in fact, if we're overweight after the age of the menopause, or if we drink 2 or more units of alcohol a day, which isn't actually very much, these two issues independently are greater risk factors for breast cancer than taking HRT for more than 5 years after the age of 50. And many women will not be aware of that level of risk. So in fact, breast cancer risk from HRT is actually very small. It's really, really important, and we have to be aware of it. But it's really important to try and get the risk into perspective and to try and weigh up risks against benefits. So for women who are having severe symptoms that's affecting their quality of life or have risk factors for having osteoporosis, for many of these women, there's going to be far more benefits than risks.
Dr. Currie, can menopause affect my sex life? And if yes, what can I do to improve that?
We have carried out several surveys on the Menopause Matters website asking specifically about libido, about sex life, about discomfort, because a lot of women find this whole issue very embarrassing. And our understanding is that it can have a big effect on sex life for various reasons. With the lack of estrogen, the most obvious effect is a change in the vagina. The vagina can become thin, dry, fragile, uncomfortable, less responsive. It can also be effect on the circulation to the clitoris, so you can have less effect on that with the lack of estrogen. And this can hugely affect the sexual satisfaction and responsiveness. And we are aware that many women find this very embarrassing and difficult to talk about. We've had information from surveys that they make excuses not to have sex to their partners because they don't feel able to talk about it. And sadly, many women do not seek help. They just put up with this. They don't actually go and discuss it with a healthcare professional. So we're very keen that women feel much more prepared and open to talk about this. The use of vaginal moisturizers and lubricants can help the dryness, but also putting back estrogen actually into the vagina, which isn't the same as taking HRT, taking a tablet or a patch or a gel, which goes to our whole body. Instead, we can just use vaginal estrogen if that's the main effect, and that can significantly improve these changes in the vagina. The other things that's going on in the menopause can actually also affect our sex life, our libido, our interest. So if we put on weight, if we're tired, if we're stressed, if we're emotional, for women that can also have a huge effect on our sex lives. And women seem to often prioritize many other things before our sex lives. And if other things are not so good in our lives, that can have a significant effect. So the most obvious physical effect is on the vaginal changes, but there's other effects around that can affect it. So again, being able to talk about it, get information, treat the vaginal changes can have a big improvement. And talking to our partners as well. It's very sad for me that a lot.
Thank you, Dr. Currie. Thank you so much for talking to me today.
You're very welcome. I hope that's been helpful.